Good morning, everybody. Thank you so much for joining us. Uh, just as a little information, we're having a little issue at the gate because of some of the students. So we have audience coming in, we have more speakers coming in, but we'll continue the session. We'll begin and then we'll have our rest of the guests join us. So today we'll begin with a panel discussion on health indicators. Before we do that, I'd like Professor P.C. Mohanan to come here and give us a brief about the health data. And I'd like to introduce him. P.C. Mohanan is a former member, National Statistical Commission. He is also working as a consultant for the Food and Agricultural Organization of the United Nations. He was also a member of several high-powered committees like Post-Structure Evaluation Committee and the Technical Group to Estimate Housing Shortage. Please come here, sir. We'll continue the panel discussion once Professor Mohanan gives us a brief about the health data.
Is it on or okay? Good morning to all of you. First correction is that there is no professor along with my name. Okay. So anyway, I must thank the organizers, Amir in particular, for bringing me here and calling me back from my retired life, rather. So let me briefly tell, because this is a topic, I will make a very general kind of talk on health indicators. One of the first things that comes to our mind when we talk about health-related data is the National Family Health Survey data. And that, fortunately, has now been released, the actual data. So all the researchers can access the data, I'm told, though I not accessed the data as such, only the reports. Now, we also have to slightly remember some of the issues that has come up with the published results of NFHS. I mean, that applies to all kinds of data. I was just mentioning to one of the young colleagues here. The moment you take out, look at any data, as a researcher or as an analyst, you need to look at how the data has been generated. Most of us don't do that. The moment we get a data which suits our argument or our hypothesis, we immediately jump to that and we are in a hurry to get it published. But very rarely we look at the generation of data, how it is generated, and whether this data collection process excluded certain population or whether some geographical areas, and whether that could impact the study. And then the sampling procedure, again, most of us, I mean, most of the users don't look at the sampling procedure. So one has to be slightly careful about, before you start analyzing NFHS data also, they have given a methodology in the booklet. I don't know how exhaustive that methodology on data collection is. This is one issue, because what I remembered when they first came out was that the NFHS showed a sex ratio of 104 or something like that. No, suddenly, all of a sudden, there seems to be massive improvement in the sex ratio, which was not acceptable. So we wrote at that time also that NFHS is not specifically designed for doing that, and whether the definition of a family means a settled family of husband, wife, children, or parents, and things like that, whether they systematically excluded individual people living alone so otherwise this could not have happened, that thing. Then secondly, most of the surveys are specifically to collect data on certain aspects, especially NFHS is on health-related parameters. So even though they may collect a lot of other data, every item cannot be taken with the same importance. They're equally good or equally valid kind of thing. So they may have a data on the household, the land ownership or income, but that doesn't mean that this is an income survey or it's a survey on land possession. So this is the kind of pitfalls we should try to avoid survey data. But NFHS is one major source of data now that is available among all those. I think the next 2 or 3 years till people finish analyzing all that, that remains the thing. Other kind of data which has come is from the Health Management Information System, HMIS, which the Government of India has administrative data source. But this has been going on for almost 15-20 years that I don't know of the HMIS data. But there are severe problems in that data. They have, as usual, all government published data in the form of dashboard. Every day the dashboard keeps changing. So you can never access data as on a date. The moment you finish your copying the data, probably it will change into something else. So that problem is there with all dashboards. So HMIS also produces a lot of dashboards. But the issue with HMIS is that we don't know the coverage. And if every day the coverage is changing, the hospitals are reporting data is increasing or decreasing or changing rapidly. So the data does not become, you can't compare the data. So this is one issue that can come with the health management HMIS data, basically. But that is why most of us prefer and support the survey data, because survey data has a much more very clear, defined, and that one of the best surveys known was that family NSSO surveys on education and health, because there it is very clearly defined instructions and it's collected from the households, and the estimates are unbiased, statistically valid. So that kind of a data set is much more preferable to the administrative databases. Administrative databases always habit of systematically excluding certain segment of the population, and nobody knows who are the excluded. But we all know there are excluded people in that. But the sample survey like the NSS are clearly well defined, and there is no exclusion of anybody. But the difficulty again is that they have a much smaller sample size. NSS covers the entire about 115,000 households or something in most other surveys. So if you start looking at the data and try to make tables or analysis for small groups of population, then there is a big problem of sampling error comes. So that is another issue which NSS kind of surveys on health. But state level, we find generally it is always there. But if you look at disease-wise kind of prevalence, or that becomes a problem with NSS in that classification. So basically, we have this health-related data coming from that. Then of course, you have these census people. They have the sample registration system that comes out with this birth registration and death registration, infant mortality and all that. So SRS data is much more, but that has been in the news so much now in the recent days, especially when it came to the COVID death. It's a health indicator, but there are so many arguments in favor of this data is right, that is right, and then we have big fight with the international organization used methodology and all that. But it helped us to come out with the drawbacks of this data set, because before this, very rarely people knew what is the sample registration system or civil registration system. But once all these controversies come out, it has helped us to understand the limitations of this data. Like the civil registration data has a lot of problem. In fact, my colleague from the Registrar General Office wrote an article which said that almost around 5 to 6 lakh deaths are registered after 1 year, every year. Except that if it happens every year, is okay. The number of 5 lakhs remains every year is registered one. But then there are so many pitfalls. But unfortunately, it so happened that this and the SRS indicator seems to agree this year. So that is something which is in support of the government's claim of the COVID death, etc. But that is not really the fact. There are so many issues which needs to be looked into. So everywhere when we look at government data, the important thing is to look at how they generated, who has generated, and not accept anything, what is published or what is claimed by the. And that applies to health-related issues too much. Because health is something which is, I was part of one of the NSS surveys on health. There are much more difficulty in collecting health-related information about these incidents of morbidity kind of issues, because most of the people in the household, if you ask the head of the household, he or she is unlikely to report the morbidity to so many people, because if they don't bother, they won't even accept that somebody is ill. So the issue used to be always there in the surveys report, but still I always prefer saying that the surveys produce a better report than the administrative thing, the HMIS data in particular, because of its incomplete nature of the data set. So these were basically what I could recollect about the three major sources: the HMIS, then NSS, and the census, and also the NFSS. But NFSS is one which is now going to be, I think, going to be used large number by most of the research people now. I hope so. Do that thing. So, is there any specific thing you want to?
On this excess death controversy.
See, what excess death is, the normal thing is excess death is always in compared with what is with the trend death. No? See, there is always a if you look at last 10 years, you know what is the average death, average number of people dying during the year. That assumes that you have a perfect civil registration system, which is so in most of the European countries. They have such a good civil registration system that they don't even conduct census now, because they know the population every minute. The moment somebody dies, it goes into the system. So many of the European countries have stopped doing the population census because there is no need for that. But in our case, the civil registration system was so bad. It used to be hardly 30-40% in the 60s. So that nobody ever used to bother about civil registration system. Then the government started the sample registration system, which is a sample of a very large sample of about 20 lakhs kind of households being paneled. Every 6 months somebody goes and reports on the birth and death. So the SRS data is supposed to be the most accurate kind of thing, much better than civil registration thing. Now, civil registration system suddenly has started showing an improvement from 2018. In fact, from 2016, 17 and 18, if you see the number of deaths, there's a drastic increase in the number of deaths reported in 2018. Why it has happened is probably they changed the software. They brought a new software to ensure that all the deaths get registered from the hospital directly and from the villages and other places. Second thing you have to remember is there are something like 3 lakh register of death and birth in India, because Panchayat level you have somebody for each. Then major government hospitals are also there. So all of them are registering the death registration. But what we know is that all the registered death may not enter in the database. Nobody knows, in fact. You get a birth certificate, we get a death certificate, we come back. It's not our headache to see whether it has actually been entered in the central database or not. So from 2018 and 19, there is a drastic increase, not because the number of deaths increased or anything. Probably they improved the reporting system or the software which they were using that. So that is why the civil registration data could not be, nobody would have thought of using that in this particular instance. And the second issue that we have seen is that, the registrations actually take place where the event takes place. The birth is registered where the child is born, not necessarily where they are actually living. Suppose for birth, the mother has visited the parent's household. Normally it is registered there. But immediately after the birth, the child and the mother may go back to her usual place of residence. So there is always a difference when you look at the state-wise. It may not match. The birth has taken place in Kerala, but the actual family lives in Bangalore or Hyderabad or somewhere else. But most important thing is that there's a delay. Legally, you can register an event within 21 days or something. But then if it is delayed beyond 1 year, you need a permission kind of thing from somebody to register it. So it's not mandatory that you have to immediately register the event. So a lot of people may not be actually registering the event immediately. But still the belief that, the government claim that 100% registrations happened is not based on actual facts. It is again based on an estimated kind of thing. So what they have done is that they have projected population. Now, because we have the actual population as of 2011, we have no census after that. So how do we know the population of 2021? It's simply a projection given by the Rajya Office. Now, a projection can be 2 crore this side or that side. That is what our experience says, that it can be varying plus or minus 2 crores. So nobody knows the actual number. So that projection they've taken now. And then they've taken the death rate as per the sample registration system, which is again a sample survey, which has an error margin. It's not that the sample registration system gives an accurate number. So they have something like 5.9 death and then 6.2 or something, the range, the confidence limits. So they've taken the estimate of that and multiplied by the estimated population to get the expected number of deaths during this year. So they have seen that expected. It is that number that they're using actually for the seeing the growth rate or the trend in the number of deaths. So this time the increase from 2020, 19 and 20, because 21 figures are just coming only. 19 and 20 shows there's a increase of about 6 lakh death in the, and 6 lakh death happens to be what is probably reported by the COVID something. So that is how they say there is a 100% kind of thing. But this question, it will not be possible to say anything on the accuracy unless we wait another 1 year and see where is the next year's data comes available from the civilization system, or we have a better estimate of the population. Only solution, according to me, is that in the next population census, one has to ask a series of questions. Whether any particular death happened during this 2020, and can that be attributed to COVID? So census is the only way in which we can sort out this issue, because government has taken a very strong stand that everything is fine. Of course, nobody would say that the modeling has been exercised, has been the right thing. No one can say that, because personally, it's also based on a lot of assumption that the World WHO model assumes certain things. They have taken the data from some of the states where the activists had obtained the data from the registration authorities through RTA and other things. So about 11 or 12 states, the data used by them is actually collected by the RTA from the government agencies. That's one thing. Then they use some of the data from this CMI or NFS also to see the number of. Now CMI, Center for Monitoring Indian Economy, their data on death is not really accurate, because they use it only to update their census household list actually. So the WHO cannot be, model may be perfect, but it all depends on what is the input in the model. So that input is still not very correct. They have recently corrected for 2 states, Germany and Spain. I think they totally revised the COVID death projections. So we can't really say much about that at this stage, only because in India also we have 2021 was where the maximum number of, the severity was very strong. So currently, all that we can say that the truth is somewhere between these two extremes. We don't know which is true, but obviously, what the government says for 2020 it may be true, but 21 we can say nothing now. And the WHO seems to be somewhere, so the truth is lying probably moving around these two numbers basically. So that is what we have been saying all along. So it's not time to make a claim that either ways. Then anything else?
Thank you.
Thank you, sir. So we'll begin with our first panel. I'd like to call on stage Professors SHAZIA FAZLI, MEENAKSHI GUPTA, SANGHMITRA ACHARYA. Please come on stage. The first panel, we will be discussing health indicators, what causes vulnerability.
So, Assalamu alaikum and very good morning to one and all present here. I am privileged. So, very good morning to one and all present here. I am privileged to moderate the panel discussion on health indicators, what causes the vulnerability. I would like to welcome you all to this session and hope this whole discussion would enlighten us as far as the aspects of women's health are concerned. So when we are talking about the gender diversity, as we all know, it refers to a wide range of gender-related identities and ways of expression. Gender inclusion means that everyone must be treated with respect, regardless of gender identity, and ensuring that systems and processes that treat all genders equally. While discussing the broad domain of the gender diversity and inclusion, we somewhere in the back of our minds have the notion of women's health also. WHO emphasizes that there must be adequate and efficient health services that are physically accessible and available to all without discrimination. Health services must be ethically and culturally appropriate for people from different backgrounds. Furthermore, these services must be scientifically sound with high quality. As soon as we start talking about availability, accessibility, affordability, and quality of health services, somewhere pops the picture of those women who are vulnerable due to their circumstances and are unable to reap the benefits of modern healthcare services. While magnitude of the vulnerable population is not clearly documented and understood, indicators such as extreme poverty show that vulnerable among women is pervasive. About for this in Indian society, women in low and middle income group often do not control resources and are culturally disadvantaged, which affects their health. When we are talking about the COVID-19 pandemic has challenged the already overburdened healthcare system and disrupted essential health services, which has further aggravated the vulnerability of women's health. So, to ponder over these issues at the stage among us, we have a versatile panel of eminent scholars. We have Ms. Meenakshi Gupta, co-founder of Goonj, and Professor SANGHMITRA ACHARYA from JNU. So, ma'am, without taking much time, let me begin with the panel discussion. So, my first question is to you, Madam Meenakshi, that what are the major factors those are related with the health vulnerability in women?
Thank you, Professor. And Namaskar and Jai Hind to everyone here. I think before I address the question here, let me just give a little bit of a background of Goonj, because that is coming from a very practitioner-driven, grounds-up. We've heard about the NFHS data and we've heard about the larger picture. And I think my being here is because we came into the issue of working on women's health from a very, right from ground up, not having kind of chartered out for ourselves that we are going to work on women's health, but our journey to women's health was a very interesting one, emerging from the vulnerabilities that are mentioned here. So Goonj basically started about 23 years ago, and we were looking at this very, very basic issue of cloth. As when we say the 3 basic bunyadi zaruratein, roti, kapda, makan. So usme kapda we felt was missing. You did not find it mentioned anywhere on the development agenda of any organization. और वो मसला आज भी बना हुआ है, वो आज भी कपड़ा एक जरूरत के तौर पे उसका जिक्र कहीं आप पाएंगे नहीं. तो जब हम लोगों ने 23 साल पहले उस विषय पे बात करनी शुरू करी, we were trying to understand कि कपड़ा एक इंसान के जीवन में क्या रोल प्ले करता है, क्या ऐसा है जो मतलब खाली तन ढकने की बात है. तो तब हम लोगों ने बहुत सारी महिलाओं से और बहुत सारे लोगों से, आदमियों से, औरतों से, बच्चों से बात करनी शुरू करी पूरे देश में, और कुछ ऐसी कहानियां निकल के आई, कुछ ऐसे वाकया निकल के आए कि जिसमें कपड़े का एक महिला के जीवन में क्या रोल है उसका जिक्र एक हमारे बिल्कुल हमको चौंका दिया उस जिक्र ने. तो आगरा के पास एक बैंगल चूड़ियां बनाने की एक बहुत बड़ी कम्युनिटी है जिनमें हम बात कर रहे थे. तो वहाँ पे एक महिला ने जिक्र किया कि कैसे उसकी एक दोस्त थी वहाँ पे, और उन्होंने, और ये मैं बात कर रही हूँ आज से 23 साल पहले की बात कर रही हूँ, तो उस टाइम पे जिक्र किया कि कैसे उनकी एक दोस्त की डेथ हो गई क्योंकि उन्होंने एक ब्लाउज का कपड़ा अपने मेंस्ट्रुएशन के लिए यूज़ किया, जिसमें कि एक हुक था जो रस्ट, उसमें जंग लगा हुआ था और उससे उनकी टेटनस से मौत हो गई। और साउथ में गए तो साउथ में किसी ने जिक्र किया कि कैसे वो कपड़ा उन्होंने बाहर, जो मेंस्ट्रुएशन के लिए वो यूज़ कर रही थी कपड़ा, वो बाहर सूखने के लिए ऐसे रखा हुआ था, तो वो उसमें एक सेंटिपिड घुसा और वो उनके शरीर में वो उन्होंने यूज़ किया और उनका देहांत हुआ। तो वो कहानियाँ जो थी उसने हमको बताया कि, क्योंकि मैं और अंशु जो हैं दो जिन्होंने कल आप में से कुछ लोग मिले भी होंगे, तो हम लोग दोनों शहरी परिप्रेक्ष्य से आते हैं, बैकग्राउंड से आते हैं, वहीं दिल्ली में पली बड़ी हूँ मैं, तो हमने कभी ऐसा सोचा नहीं था, ऐसा देखा नहीं था। तो मैं आपको इसलिए बता रही हूँ क्योंकि बहुत सारी वल्नरेबिलिटीज, बहुत सारा इवन इंडिकेटर्स जो हैं वो शायद उसमें इंक्लूडेड ही नहीं है, क्योंकि वो जो सवाल पूछे जाने हैं या पूछे जाने चाहिए वो उनको इंक्लूड ही नहीं कर रहा, वो उनकी रियलिटी से जुड़ ही नहीं रहा कि जिनकी हेल्थ के बारे में बात करने की जरूरत है। तो वो कहानियों ने हमें बताया कि एक कपड़ा जो है एक औरत के लिए एक अलग ही मायने रखता है। उसके शरीर को ढकने के लिए तो है, उसकी डिग्निटी को बचाने के लिए तो है, मगर उसको हर महीने दर महीने एक कपड़े की कमी, एक पीस ऑफ कपड़ा, उसकी कमी उसको इस क्राइसिस तक लेके जाती है कि उसके लिए वो मेंस्ट्रुएशन जो है एक मंथली डिजास्टर के रूप में तब्दील हो जाता है। तो उस जरूरत को समझने का काम जो है वहां से शुरू हुआ, वहां से हम लोगों ने उस इशू पे काम करने की कोशिश करी और हमने उसको इस तरह से देखा कि हमने कहा कि शहरों में बहुत सारा कपड़ा जो है वो ऐसे ही या तो लैंडफिल में चला जाता है या किसी के घरों में अलमारियों में बंद है। तो गूंज का काम जो है एक बड़े स्तर पे शुरू हुआ, लगभग आज 27 राज्यों में है, और ये हुआ कि हम शहरों से बहुत सारा कपड़ा इकट्ठा करें, उसमें से बहुत सारा कपड़ा जो है शायद पहनने के योग्य ना हो, मगर उस कपड़े में कॉटन कपड़ा निकालें जो एब्जॉर्ब कर सकता है, सोख सकता है। उससे हम लोगों ने पैड बनाने शुरू किए, जो माई पैड के नाम से हम लाखों की तादाद में बना रहे हैं और शहरों में, गाँव में महिलाओं तक पहुंचा रहे हैं। इट गोज थ्रू अ वेरी डिटेल्ड प्रोसेस कि उसको धोया जाता है, धूप में सुखाया जाता है, आयरन के वो सारा मॉइस्चर निकाला, तो वो सारा प्रोसेस के थ्रू गुजर के वहां तक पहुंचता है। बट जब हम लोगों ने कपड़े पे ये काम करना शुरू किया, हमने सोचा कि अच्छा शायद कपड़े की जरूरत है तो हम वहां पहुंचाते हैं। बट जब कपड़े से जोड़ने की कोशिश की तब हमने और कहानियां निकल के आनी शुरू हुई, और वो कहानियां लोगों, महिला की अपने परिप्रेक्ष्य में, अपने गांव में, अपनी कम्युनिटी में, अपने परिवार में एक बहुत ही मतलब कॉम्प्लेक्स है, जिसे कहते हैं ना, एक मसला निकल के आया कि कैसे उसको पानी की कमी है जो मेंस्ट्रुएशन से जुड़ जाती है, एक प्राइवेट स्पेस का जहां वो नहा भी सके उसकी कमी होना, उसको मेंस्ट्रुएशन का, उसकी मेंस्ट्रुअल हेल्थ से जुड़ जाती है, उसका अपनी मतलब मेंस्ट्रुएशन के बारे में बात भी कर पाना वो उसकी मेंस्ट्रुअल हेल्थ से जुड़ जाता है। उसके जब आप क्योंकि अभी बात जिक्र हुआ कि इन्फेंट मोर्टालिटी की बात होती है, एनएफएचएस में आप उसको कैप्चर करते हैं उस डेटा को, बट रिप्रोडक्टिव हेल्थ का जो पूरा इतना बड़ा काम है इस देश में, उसमें मेंस्ट्रुअल हेल्थ का जिक्र ना होना, मतलब आप यकीन जानिए बहुत सारे आशा वर्कर्स, बहुत सारे हेल्थ पीएचसीज में वो जाते हैं और प्रेग्नेंट महिलाओं से उन्हीं गांव में जाते हैं, बात करते हैं, पूछते हैं, उनको सारी दवाइयाँ, सारी अवेयरनेस देते हैं। मगर मेंस्ट्रुएशन के बारे में, एक महिला का मेंस्ट्रुएशन का क्या हालचाल है उसके बारे में कोई नहीं बात करता। तो जो चीज इंडिकेटर्स में ही नहीं आ रही, वो कहाँ से उसके ऊपर कोई एड्रेसल होगा, कहाँ से उसकी कोई मतलब कोई भी पॉलिसी इशू निकल के आएगा। तो हमें ये समझ में आया कि ये सब चीजें हैं, जैसे जो अभी आपने भी जिक्र किया कि एक्सेस का इशू है, बहुत बड़ा इशू है। आप शहर में जितनी आसानी से पैड जाके खरीद सकते हैं, गांव में एक महिला के पास पहले तो मार्केट ही नहीं है, और अगर उसको भेजना भी है तो अपने आदमी को या घर में किसी को कहना है कि तुम मार्केट जो 5 किलोमीटर 10 किलोमीटर दूर है वहां से लेके आना है, तो किसी को बोलना पड़ेगा उसको। दूसरा एक अफोर्डेबिलिटी का इशू तो है ही, वो तो एक बड़ा इशू है कि जो एक महिला की इकोनॉमिक फ्रीडम से या उसकी ताकत, इकोनॉमिक ताकत क्या है उससे जुड़ता है। पर इन सबसे बड़ा इशू जो हमको दिखाई दिया जब हम इसको पिछले 23 सालों में इस पे काम करते रहे, तो इन सब के ऊपर एक इशू दिखाई दिया कि एक महिला का अपनी मेंस्ट्रुएशन के बारे में बात ही ना कर पाना। तो मुझे लगता है कि जो बड़ा विषय है, एक सोसाइटल लेवल पे अगर विषय है, तो जिस विषय को, जैसे मेंस्ट्रुएशन के बारे में बहुत फिल्में बनी, बहुत ऑस्कर विनिंग वो हुआ और बहुत सारी चर्चाएं हुई, बट क्या हमने इस देश में जाके महिलाओं से पूछा भी कि भाई आपके मेंस्ट्रुएशन से जुड़े हुए मसले क्या क्या हैं? हमने एक प्रोडक्ट को एक उसका सेंटर माना। मेंस्ट्रुएशन में आपको एक मतलब अगर आप समझे तो शायद हेल्थ को एक बड़ा तालाब समझे और मेंस्ट्रुएशन उसकी एक छोटी सी एक चीज है जो बहुत बड़े लेवल पे जुड़ती है एक महिला के जीवन से, उसकी हेल्थ से। तो अगर हम उस सुई से समझने की कोशिश करें कि भाई कहाँ कहाँ वल्नरेबिलिटीज पैदा हुई हैं या हैं और कहाँ कहाँ इंडिकेटर्स हम शायद मिस कर गए वो, तो एक महिला की हेल्थ का लार्जर हेल्थ सिस्टम में या मेंस्ट्रुअल हेल्थ का लार्जर हेल्थ सिस्टम में ना इंडिकेट होना, या एक पीएचसी में या बड़े हॉस्पिटल में उसकी मेंस्ट्रुएशन पे कोई पैड ना होना। आप कहीं जाएं किसी पीएचसी में, कहीं कोई पैड नहीं है। या डिजास्टर्स में, आई एम ट्राइंग टू टच अपॉन द वेरियस एस्पेक्ट्स ऑफ वेयर मेंस्ट्रुएशन बॉदर्स अ वुमन एंड वेयर इट्स नॉट टेकन अप। डिजास्टर्स में एक रिलीफ किट में एक पैड का ना होना, या अभी जब कोविड में महिलाएं, जब बहुत सारे लोग जो माइग्रेट कर रहे थे वापस जब चल के जा रहे थे, उसमें हर एक मेंस्ट्रुएटिंग महिला जो थी वो भी चल रही थी, ना कहीं टॉयलेट था, ना कहीं प्राइवेट स्पेस थी। मुझे बीड़ में हमारे जो पार्टनर ऑर्गेनाइजेशन है जो काम करते हैं, उनसे ऐसी इतनी भयावह कहानियां बोले कि वो जैसे मुंबई से और वापस चल के लोग बाग आ रहे थे, बीड़ जो माइग्रेंट वर्कर्स गए थे वो वापस आ रहे थे, उसमें कई महिलाएं थी। और बता रही बीड़ के गांव में वो महिलाएं जब वापस पहुंचती है, वो काफी चली हैं, कुछ जगह पे उनको ट्रैक्टर मिले जिसमें उनको बैठना था और कई किलोमीटर तक उनको चलना था, मतलब उस पर जाना था। आई डोंट नो आप में से कितने लोग ट्रैक्टर पे कभी चढ़े हैं। इट्स द मोस्ट अनकंफर्टेबल एक्सपीरियंस। और आप मेंस्ट्रुएट कर रही हैं, कहीं 2-3 घंटे के लिए अगर रुके, कहीं भी रुक जाएंगे आदमी, तो आप नहीं कह सकते कि किसी आदमी को, अनजान लोग हैं, आप नहीं कह सकते किसी आदमी को कि कैसे मुझे कहीं रुकना है, चेंज करना है। तो वो आप कहीं झाड़ी में कहीं पे गए और फिर वो बताते हैं, वो जब वो वापस पहुंची, जब महिलाएं, उनकी हालत ऐसी थी कि वो खड़ी भी नहीं हो पा रही थी। उनकी जांघें, उनका शरीर इतना छिल चुका था कि उनका बात करना भी, उनको कई मतलब दिनों तक उनको बैठने की भी हालत में नहीं थी। मसले महिलाओं की हेल्थ के, आई थिंक उसकी कई परतें खुलना अभी बाकी है, क्योंकि महिलाएं अपनी बात को, अपनी हेल्थ की बात को कह भी नहीं पा रही हैं पूरी तरह से। ऐसा महसूस होता है जब हम गाँव में, हम क्या करते हैं, हम बहुत हजारों गाँव में जाके महिलाओं के साथ चुप्पी तोड़ो बैठक करते हैं, ब्रेक द साइलेंस, क्योंकि अपनी हेल्थ को आगे रखना, उसको समझना, उस पे भी मेंस्ट्रुअल हेल्थ को समझना और आगे रखना, ये बहुत परत दर परत वाला विषय है। और तब हम समझते हैं कि अच्छा, आप किसी गांव में किसी महिला को पानी का विषय है, किसी महिला को किसी गांव में प्राइवेट स्पेस का विषय है, कॉन्टेक्चुअलाइज्ड है, वो अलग अलग कॉन्टेक्स्ट में अलग अलग तरह से उभर के आ रहा है। तो इस पूरे विषय के पीछे एक बड़ा विषय है कि एक महिला की डिग्निटी, एक महिला का सम्मान, एक महिला की हेल्थ और वेलबींग का मसला, वो आपस में कहीं ना कहीं जुड़ा हुआ है। ऑफ कोर्स उसका इकोनॉमिक एस्पेक्ट है, ऑफ कोर्स उसका सोशल एस्पेक्ट है, कल्चरल एस्पेक्ट है, बट एक सम्मान का विषय जहां जुड़ता है, एक महिला को 5 दिन तक, 12 साल की उम्र से जब महिलाएं मेंस्ट्रुएट करती हैं, बच्चियां मेंस्ट्रुएशन शुरू करती हैं, और 50 साल की उम्र तक जब तक मेंस्ट्रुएशन चलता है, हर महीने दर महीने ये सारी तकलीफें झेलती हैं महिलाएं, और बात नहीं कर सकती उसके बारे में। तो आप सोचिए कि अगर मैं हेल्थ इंडिकेटर्स के पॉइंट ऑफ व्यू से सोचूं, या एक ह्यूमन राइट के पॉइंट ऑफ व्यू से भी सोचूं, तो एक महिला का अपने शरीर के बारे में क्या सोच बनती होगी, एक महिला की अपने बॉडी कॉन्फिडेंस या अपने हेल्थ सीकिंग बिहेवियर के बारे में क्या सोच पैदा होती होगी। इन सब एस्पेक्ट्स पे कहीं ना कहीं सोचने की जरूरत है, क्योंकि ये अभी इंडिकेटर्स में कहीं नहीं आ रहा है। तो मुझे सिर्फ कुल मिला के ये कहना है कि बहुत सारी चीजें ऐसी हैं जो शायद मैपिंग से बाहर हैं अभी महिलाओं की हेल्थ के बारे में। I'll stop here.
Okay, thank you so much, ma'am, for your information, which is very insightful and thorough understanding of the field. आपने जिन जिन बातों के बारे में बताया, really these are eye openings for us, क्योंकि how cloth is important in the population which is marginalized, and how they are using that clothes, and we don't think about this. हम लोग सोचते ही नहीं है कि ऐसा भी हो सकता है, या किसी की जिंदगी में क्लॉथ की ये यहाँ तक की भी इम्पोर्टेंस नहीं हो सकती है कि मतलब उसको वो क्लॉथ उसके लिए उसकी जिंदगी से कहीं जाके जुड़ जाए। बहुत ही इंसाइटफुल और बहुत ही आई ओपनिंग डिस्कशन रहा आपका। और आपने जिस तरह बताया कि कहीं हम लोगों ने हेल्थ में मेंस्ट्रुएशन को तो कहीं जगह ही नहीं दी है, ये फॉर ग्रांटेड लेते हैं। वी ऑल टेक फॉर ग्रांटेड दिस कि मेंस्ट्रुएशन तो होता ही है, दिस इज द पार्ट ऑफ द विमेन, दिस इज द पार्ट ऑफ द गर्ल्स लाइफ, ये तो होगा। जब वो 12 ईयर की हो जाएगी तो वो तो उसकी जिंदगी में शुरू ही हो जाएगा, इसकी तो कोई अलग से इसको एड्रेस करने की जरूरत नहीं है। बट आफ्टर दिस डिस्कशन रियली वी रियलाइज that how menstruation is also important in the life of every woman. अगर हम सच में सोचें इसके ऊपर तो हर इंसान की जिंदगी में बहुत रिलेटेड है। बहुत सारे साइकोलॉजिकल प्रॉब्लम हो जाते हैं, बहुत सारी बार हम सही में मूव नहीं कर पाते इजीली फ्रीली यहाँ वहाँ, लेकिन हम उसको फॉर ग्रांटेड लेते हैं और ये मान लेते हैं कि ये होता है, इसलिए हम कभी उन पर इतना सोचते नहीं हैं। और दूसरी बात जो आपने कहा कि स्टिग्मा इज ऑल्सो अटैच विद द मेंस्ट्रुएशन, कि अगर हो गया तो हम किसी से कह भी नहीं सकते, किसी से बता भी नहीं सकते, तो ये भी एक बहुत बड़ा इशू है जो हमें एड्रेस करना चाहिए। और दूसरी बात जो आपने माइग्रेंट वर्कर्स से रिगार्डिंग कही, रियली इट वाज शॉकिंग कि जब एक जगह से दूसरी जगह लोग जा रहे हैं तो वो अपने पर्सनल हाइजीन को तो छोड़ ही दीजिए, जो पर्सनल नेसेसिटीज हैं उनको भी एड्रेस नहीं कर पा रहे थे। हाइजीन तो बहुत दूर की बात है, जिस हेल्थ और हाइजीन बड़े बड़े जार्गन्स यूज करते हैं, दीज आर वेरी फार फ्रॉम दिस पॉइंट। और रेस्पेक्ट, यस, रेस्पेक्ट शुड बी देयर। हर विमेन का राइट है कि रेस्पेक्टफुली उसको ट्रीट किया जाना चाहिए, लेकिन नहीं किया जाता, ये भी एक बहुत बड़ा इशू है। और ये एक ऐसा इशू है जिसको हमको जरूर एड्रेस करना चाहिए। और एक्चुअली मार्जिनलाइज्ड पॉपुलेशन डजंट नो अबाउट कि हाउ दे कैन यूज देयर राइट, उनको पता ही नहीं है कि हमारे क्या राइट है और हाउ कैन वी यूज दिस। So these are the major problems those you have addressed. Thank you so much, ma'am. My next question to you, Professor Acharya, ma'am. Where will you place women's health in the social fabric of Indian society?
Thank you so much, Professor SHAZIA. आप सभी को मेरा आदाब। मैं कोशिश करूंगी कि मीनाक्षी जी ने जहाँ पे इस चर्चा को लाके छोड़ा है, मैं वहाँ से आगे बढ़ने की कोशिश करूंगी। और इस कोशिश में शायद जो मैं पहले कहना चाह रही थी, मीनाक्षी जी ने उसका डायरेक्शन थोड़ा सा चेंज कर दिया है। Nevertheless, I would still want to share what I have in my mind. शाजिया जी, अब जब आप मुझसे ये पूछना, समझना या मेरी बात मुझे रखने का मौका दे रही हैं, मुझे लगता है जब हम महिलाओं के स्वास्थ्य की बात करते हैं तो वो सिर्फ हेल्थ ही नहीं होता है, इट्स मच बियॉन्ड हेल्थ. वी ऑट टू बी सीइंग हाउ डू वी कनेक्ट हेल्थ with every other aspect to which health is connected. Employment, for example, being educated, for example, the access to various kinds of services, amenities that I may have. And that's where precisely I would immediately connect with Meenakshi ji's conversation on this very menstrual hygiene. RCH1 comes sometime in mid-1997, 5 to 7 is where it comes in. We see nothing being talked about adolescent health. Thankfully, in the second phase, we do start talking about adolescent health. In the garb of adolescent health, we are surreptitiously mentioning about menstrual health. We're trying to tell young girls किशोरी स्वास्थ्य योजना के तहत हम उनको बताना शुरू करते हैं कि तुम आयरन फॉलिक भी खा सकते हो, तुम ये भी कर सकते हो, वो भी कर सकते हो. लेकिन जब ये पर्सनल हाइजीन की बात आती है, मेंस्ट्रुएशन की बात आती है, तो सबसे पहले शायद चुप्पी तोड़ो इम्पोर्टेंट हो जाती है. How many of us have had a conversation on menstruation with our mothers or sisters or aunts? I'm not too sure that many of us have had this conversation. And I'm talking about my generation. I'll be glad if the younger ones have had that conversation. And that's where perhaps the question begins, why do we shy away from something which is so very natural? If childbirthing can be alleviated to the realms that it is, menstruation में क्या दिक्कत आ जाती है कि हम बात भी नहीं करना चाहते, हम relief kids में उसको add नहीं करते क्योंकि most of the kids will be accepted by men and men will be embarrassed to accept that kid. और ये कश्मीर का जब flash flood हुआ तब भी हमें पता चला और जब ये उत्तराखंड का हुआ तब भी हमें पता चला. And I'm saying this by way of some of my own experience on the field. जो आपने महिलाओं की when they were traveling, the migrant women, menstruating migrant women when they were traveling, even otherwise हम स्वच्छ भारत के तहत टॉयलेट्स बना रहे हैं, but we've never talked of bathing spaces for women. गांव के गांव हमें घरों में महिलाओं ने बताया कि टॉयलेट तो हमारा तमाम सारा जंगल पड़ा हुआ है और हम जा सकते हैं. And at that point, I really thought there was nothing wrong in going and doing that open defecation, जिसको कि इतना vilify कर दिया गया है. नहाने की जगह हमारे पास नहीं है. We kind of can't do anything which is pertaining to menstrual hygiene vis-a-vis changing the cloth, washing the cloth, उसको सुखाना है वगैरह वगैरह. तो मेरे ख्याल से मीनाक्षी जी, you've really given me a different kind of direction to deliberate at the moment. और इस सारे context में मैं perhaps दो बातें कहना चाहती हूँ. एक तो ये जो मैं कह रही थी कि बावजूद इसके कि women को हम बहुत अलग तरह से child bearing के context में बहुत सारी तवज्जो देते हैं, लेकिन जब the context of her own health comes, तब हम उसको शायद कहीं भूल जाते हैं. Women's health is prioritized at the end of every other priority, चाहे वो health हो, चाहे वो किसी और किस्म का expenditure हो, and that comes from one data after the other. There's ample evidence that the data is giving us, right from NFHs to the micro level studies that we have at our disposal to kind of deal with. So बावजूद इसके कि health becomes very important in what we've been trying to access vis-a-vis महिला सशक्तिकरण. एक तरफ हम सशक्तिकरण की कुछ चीज़ों के बारे में सोचना शुरू करते हैं, लेकिन स्वास्थ्य कहीं ना कहीं पीछे रह जाता है. और उस पीछे रह जाने में शायद this is the point perhaps I would like to invoke certain realms in which we perceive health. कल मेरे ख्याल से हमारे फर्स्ट डिस्कसेंट ने गांधी जी को इन्वोक किया था कि he was very instrumental in making women participate in the freedom struggle. And I think at this point I would probably want to invoke Ambedkar's concern for women's health. शायद हम में से कुछ लोगों ने या काफ़ी सारे लोगों ने इस बारे में पढ़ा भी होगा. जब हम आमतौर पे हेल्थ की बात करना शुरू करते हैं तो फर्स्ट थिंग दैट वी स्टार्ट perhaps marking our deliberations are with Bhore Committee report. Joseph Bhore Committee जिसने 1946 में हमें ये बताया कि हमारे जो देश की जनता है उसका health is really pathetic and we need to do something about it. और subsequent कई सारे reports हैं जो इसकी बात करती हैं. लेकिन इससे कहीं पहले जब हम अम्बेडकर का जिक्र करते हैं महा टैंक मूवमेंट से, उस टैंक मूवमेंट से जो एक्सेस टू सेफ वाटर की बात करता है, हमने उसको एक ऐसे मूवमेंट के तौर पे शायद ज़्यादा देखा है कि इट वाज कॉलिंग फॉर द दलित असर्शन. For sure it was, but in that Dalit assertion there was some kind of intention that what is needed is safe access to safe drinking water for all of us equitably. ये सेफ ड्रिंकिंग वाटर सिर्फ एक तबके का प्रेरोगेटिव नहीं हो सकता है, इसलिए ज़रूरी था कि सभी को इसका एक्सेस होना चाहिए. ये अलग बात है कि उस मूवमेंट में ज़्यादातर पार्टिसिपेंट्स जो थे वो दलित महिलाएं थी. सो द कॉन्टेक्स्ट दैट देयरफॉर आई एम ट्राइंग टू ड्रॉ इट, वहाँ से शुरू होता है. मेरी जो समझ बनती है इस बारे में जिक्र करने की, वो वहाँ से होती है. Subsequently, when Ambedkar is talking in his deliberations about how the women emancipation can be taken on board, he very consciously talks in this Bombay Legislative Council Assembly में जो उनका जब वो 10 नवंबर 1938 में कहते हैं कि जो हम डिसेबिलिटी को हेल्थ और आउटकम ऑफ हेल्थ से कनेक्ट करते हैं, वो ज़रूरी है महिला के स्वास्थ्य को ध्यान में रखते हुए करने की. और ये सिर्फ दलित महिलाओं की बात नहीं कर रहे थे, ही वाज टॉकिंग अबाउट ऑल विमेन. एंड थैंकफुली आई थिंक एट दैट टाइम पॉइंट वी weren't so polarized. And I really take pride in saying कि मैं उस शहर से आती हूँ जहाँ हिंदू मुस्लिम का जो डिवाइड हम आज महसूस कर रहे हैं वो कहीं नहीं एहसास होता था. वहाँ पे शिया सुन्नी का जो डिवाइड है वो उभर के आता था. एज किड्स वी ग्रोन अप काइंड ऑफ गेटिंग टू नो अबाउट दैट. हमें ये हिंदू मुस्लिम डिवाइड तो आज इस वक्त आके समझ में आता है कि अच्छा ऐसे भी हो सकता है. आई मीन व्हेन आई गो बैक टू माय सिटी, that's what the sense I get. I mean, it's been ages that I've not been able to see some of my friends because of divides that have been created. So कहना मैं ये चाह रही हूँ कि जो बात हम आज की तारीख में अल्मा अटा कॉन्फ्रेंस के बाद हेल्थ फॉर ऑल 1978 की बात कर रहे हैं, वो डॉक्टर अम्बेडकर ने 1940s में 1930s में कहना शुरू कर दिया था कि physical disability of the parents can be detrimental for the growth of the child, and therefore he suggests that limiting the family size is something which is important for the health of the family. तो मेरे ख्याल वो बहुत बड़ी बात है जो उस जमाने में उन्होंने कही, और वो बात हम आज की तारीख में कह रहे हैं विमेंस हेल्थ को लेकर हमें ये करना है वो करना है. लेकिन कहीं ना कहीं when we relate this to the state and the population policy, ये लिमिटिंग का जो कॉन्सेप्ट है वो पॉपुलेशन कंट्रोल, इफ आई कैन यूज दैट फ्रेज, उसके कॉन्टेक्स्ट में ज्यादा किया जाता है बजाय विमेंस हेल्थ की कंसिडरेशन को लेके. तो वहाँ से शुरू होके अगर हम ये बात को समझें कि आज जो हम मैटरनिटी बेनिफिट्स की बात कर रहे हैं, आज जो हम वर्क ड्यूरेशन 8 आवर्स अ डे की बात कर रहे हैं, ये सारा लेजिस्लेटिव असेंबली के उस डेलिबरेशन के बाद दैट कम्स इनटू फोकस. माइका माइंड्स में करने की वजह से क्या स्वास्थ्य पे प्रभाव पड़ता है वो वहाँ से निकल के आता है. व्हेन ही वाज पार्ट ऑफ दैट जो प्रपोजल दिया गया था माइका माइंड वर्कर्स को की सोशियो इकोनॉमिक कंडीशंस को समझने के लिए, तो ये सारे काम उस वक्त हो रहे थे. और आज भी हम यहाँ बैठ के महिलाओं की जो परिस्थिति है उसकी बात कर रहे हैं. A quarter of the women in India, going by the NFHS survey, what Professor Bhanan has just talked about, we are still, हमारा अगर BMI index देखा जाए तो 18.5 से कम है, which means we are thin. और उसमें से एक बहुत इंटरेस्टिंग बात है, अगर आप उसको रिलीजन वाइज डिसएग्रीगेट करें तो मुस्लिम विमेन का जो थिननेस है, अगर हम लोग BMI की कैटेगरी को देखें, is lesser than the Hindu women. Contrast that with the obesity. You have more Muslim women who are obese as compared to the Hindu women. वहाँ से perhaps we get that connect कि जो हम poverty के linkages draw करना चाहते हैं, जो हम perpetuated inequality in terms of access to literacy, access to educational attainment की बात करना चाहते हैं, वहाँ से वो connect हो जाता है. obesity, we very well connect with how and what we eat, and how and what we eat is so much governed by what we earn also. Where are we living? What is it that we are in terms of being able to access in terms of resources. तो मेरे ख्याल से ये एक अलग किस्म की vulnerabilities हमारी बन जाती हैं, ना केवल हमारी जो हमारे हेल्थ का कंडीशन हो सकता है, पर उससे जुड़े हुए सारी चीज़ें. हमारी रिहाइश अगर स्लम्स में है, we are exposed to certain kinds of environmental conditions, और ये बहुत likelihood है कि बहुत ज़्यादा वो है कि हम में perhaps we'll be suffering from if nothing else respiratory problems हो सकती हैं. टॉयलेट फैसिलिटी है कि नहीं है उस पर डिपेंड करता है. A lot of women's health problems are generated because of the fact that you do not have spaces where you can go for urination, or containing urination for a long time we know has its own implication on the health of reproductive health of the women. तो एक तरफ हमने तमाम सारे programs बनाए हुए हैं, a number of international agencies which are dealing with reproductive health, yet we haven't really made much changes when it comes to reproductive health. एक और बात कह के शायद मैं खत्म करूँगी, sorry. कोई भी इंडिकेटर ले ले, अब we can keep on talking about one indicator after the other. We can see very, very marked difference between, particularly the non-Muslims and the Muslims. Among the non-Muslims, if we get to kind of disaggregate the minority communities, the one which is smallest, the Parsis, are doing the best in all possible indicators as compared to perhaps when we look at the largest minority, religious minority population in the country. So that's why perhaps I get down to think about what are the concerning factors in which we locate this communities, populations, and then perhaps very essentially see them that the vulnerabilities are being generated by multiple factors, and we need to take into account those multiple factors. The out-of-pocket expenditure that we get from these data sets and relying back on NFH is giving in all the considerations for how we need to look at this data. We have a fairly strong difference that we have between what is it that the Muslim women are spending in a public sector for delivery. That's something to the tune of 4,000 plus rupees versus the Hindu women who are spending about 2,700 something. Right. In fact, I'm still trying to figure out why is this difference there if it's a public sector provisioning, and I really have to look into it to be able to give a good, viable answer to this question. Why is it that we have? And that perhaps brings me to the last point in terms of the stipulations by way of the population policy itself that restricts women in terms of their own number of children that they have by way of participating in the PRI elections, by way of accessing to the PDS, etc., etc. Maharashtra being one of the states which was one of the first states to stop the PDS available access to PDS services if you had more than 2 children. Similarly, after the second child, you are not, you can't access public sector services for childbearing. So the contentions which are often made vis-a-vis the fertility levels and the differentials in fertility levels have to be superimposed with these other connects, other vulnerabilities of economic disparities, of residential qualities that we are embedded in before we actually come to the conclusions. So with that, Professor SHAZIA, I'll end because I think we can go on and vulnerabilities. Thank you so much.
Thank you so much, ma'am, for your insightful discussion. Really, you have addressed so many important points that why women are shy and why they are not talking about their normal health processes and normal health conditions in front of others. जाहिर सी बात है जो चीज़ बिल्कुल हमारी लाइफ का पार्ट है, मेंस्ट्रुएशन जो बिल्कुल हमारी लाइफ के साथ जुड़ा हुआ है, उसके बारे में हम क्यों बात नहीं कर सकते? दिस इज अ वेरी वेरी रेलेवेंट क्वेश्चन which you have asked here. And you have also discussed about the Ambedkar concern. Really, in India, we know that we were discussing in the ancient time, and we were discussing about the other British period and all, about the health of the women. ये नहीं है कि कोई हम नया इशू आज डिस्कस करने के लिए जा रहे हैं. बिल्कुल आपने सही कहा कि अल्माटा में 1978 में लिया गया, उसके बाद 1994 में ICPD की कॉन्फ्रेंस में भी इसको एड्रेस किया गया कि women are having rights. उनको अपने राइट्स के बारे में बोलना चाहिए. उनके लिए सिर्फ इतना ही ज़रूरी नहीं है कि वो एक रिप्रोडक्टिव हेल्थ से जुड़ी हुई हैं, उनके लिए ये भी ज़रूरी है कि कब, कहाँ और कैसे डिसीजन लेना है. दिस इज द राइट ऑफ द विमेन, बट वी आर वेरी फार फ्रॉम दैट पॉइंट. अभी भी हम वहाँ तक नहीं पहुँच पा रहे जहाँ हमें पहुँचना चाहिए. इसलिए आज 21st सेंचुरी में यहाँ बैठकर हम इस बात पर डिस्कशन कर रहे हैं कि व्हाट आर द मेजर कंपोनेंट्स ऑफ द vulnerability among women, especially in the Muslim women. When ma'am said that कि वाकई बहुत थिन डाटा मिलता है, हम हर चीज़ में देखते हैं कि मुस्लिम विमेन और भी ज़्यादा पीछे हैं इन कंपेयर टू द अदर रिलीजन. So, ma'am, thank you so much again for your discussion. My next welcome, sir, to this discussion, panel discussion. My next question to you, Mr. Banik. What role do NGOs play in addressing the health issues of women, and to what extent women are benefited from such a scenario?
Okay, so first of all, because I first here.
Yes, I know.
And, I have no clue as to what the discussion happened so far. So
The-
my answer would be on the basis of some of the work that I've done on the
Okay.
on the gender aspect of this thing. So I'm an economist, so we were working on this NFHS data, and maybe I can share some experience from that data. And we were looking at this whole concept of open defecation in India, because health and open defecation are kind of related to one another. So some of the things that we've found, and this is already published in Empirical Economics, is in spite of the government building toilets, in terms of the demand for toilets, in comparison to other consumer durables. So we look into, because if you look into the NFHS data, you will find that there are 21 different consumer durables, like telephone, cycles, then TV, televisions, radio sets, so on and so forth, right? And what we found was, in spite of the government building toilets, in terms of priority, basically we ran a logistic regression. In terms of priority, what we found was toilet is getting a much lower rank, which is basically saying that just by intervening by building more toilets is not going to help. Now here, what we found, again, quite interestingly, is for the household where you have women as the head of household, because if you're looking into the state of Kerala, or for that matter, the northeastern states, you have the woman who actually running the household, as compared to some of the patriarchal states, in particular UP, Haryana, and the entire Jharkhand belt. What we found is, in terms of women empowerment, in terms of the health aspect, health data, in terms of the outcome of infant mortality and stuff like that, it is much lesser in the states, in the states where it's a patriarchal society. But for the states where it's a matriarchal society, the health outcome or the results are much better compared to, which is basically saying is, if I control for the who is heading the household, you will find that in terms of outcome variable, for the southern states and the northeastern states, for the woman, it is much better compared to the northern states. So that is one point that we found out. The second point, what we found was, we also control for the level of literacy among the women. And we looked into the number of women who have crossed 10th level exam, 10 plus 2, and graduate and postgraduate. And interestingly, the more the study a woman does, the better is not only the health outcome, because as you know that health, income, and education, these are three important components of development, and these three are interrelated to one another. And we in fact found that for the household where the women are more educated, or the women who are more empowered, they have better outcome in terms of health. So that is another important finding from our study. We also control for the religion, and this is also quite important. And we found that typically the Muslim household, there the indicators, the health indicators are much better. So when we actually dig a little bit deeper, what we found that the Muslim has the concept of washing their hand 5 times a day, and that in a way has led to a better health outcome among the Muslim families. So that is another important finding from the study that we found, that in terms of infant mortality rate, we found that the number of infant dying among the Muslim household are much less compared to the non-Muslim household. So that is controlling for the religion. So these are the three important things that we found from our study. And this paper got published in Empirical Economics, which is an A-rated journal. And without actually hearing much about the previous discussion, I think it's not wise on my behalf to comment. But these are some of the things that which came out from our study. And regarding the NGO, you mentioned about the NGO. I, at some point of time, was working with Rajiv Gandhi Foundation. And there I have had the opportunity of visiting or doing some field visit and trying to see that whether the money which has been given are being used properly. So there also, what happened is when we talk to some of the district magistrate or some of the gram panchayat, let's say in a given gram or in a village, you need more, the necessity of having a more primary healthcare is more compared to, let's say, having a primary education center. But because the government is giving money, which is channeled towards a particular type of intervention, even so, for instance, in a particular village, we found that the district magistrate was saying that it's more important, they will benefit more by opening a primary healthcare. But the money which was given was actually for building a primary school. So this kind of thing, I think, if you give the flexibility in terms of using the money in terms of what is being more necessitated, I think it would make much difference at the ground level compared to what we see otherwise. So that is one small observation, having worked with few NGOs, and the NGOs were basically telling us that, look, we can't go beyond what the government is asking us to do, because our job is to look into the delivery aspect of it. But whether the money will go for education or for cutting ponds or rainwater harvesting, or for that matter, building more primary healthcare, is something which is beyond our control. So therefore, I think in terms of delivery, it makes sense from the NGO perspective. But in terms of making real difference on the ground, what makes sense is, can we allow a little bit more flexibility when it comes to usage of funds? That would be my short answer.
Thank you so much, Mr. Banik. Really, you have raised very good point that the funds should be flexible to use in the fields. And another thing, you have said that health is directly related with the education of the women. Yes, it's true. You have discussed in a very good manner. And another thing is that the matriarchal society is doing better in comparison to the patriarchal society. Yes, because these things are really very, very good and informative for us. So thank you so much, Mr. Banik. My next question is to Miss Meenakshi Gupta, to you. That what are the major health issues among most marginalized sections of women, like sex workers, inmates, etc.?
Thank you. Great that you asked this question about the most vulnerable women. And we at Goonj, we've been trying to understand, even before COVID, that and my analogy or my work or my comments will come from the space of working on menstrual health, but I guess it is an indicator of larger aspects of health, women's health. So going back to my story about how we've come to work on menstrual health, and when we were working, we realized that there were these, again, coming from ground up stories, things we were seeing on the ground. Some stories I'll share. So one very big segment of women whose menstrual health and hygiene issues have as yet not made it to the mapping are disabled women. So one story, and this was, we were working with Anandwan, the ground of the leprosy work which has come up out there. And there they also had a group of women who were blind, right? And it was a shock to understand that a blind woman or a blind young girl, when she first menstruates, she has no way of knowing that she has started to menstruate, or her clothes are there's some stain on it or anything like that. Or simple thing like for a blind woman to know which side of the pad and how it has to be put in. Now this small thing has such a basic connection with how she's supposed to deal with her menstrual hygiene. Or women who are who have some mental health disability. Now there are cases and stories, and this is all published stories which you can access from the net. That many families who have daughters, for example, who are having a mental health issue, they tend to get their daughter's uterus taken out before they start, or around the time they would start menstruating, because it's very, the daughter is very vulnerable to any kind of abuse, and she would not know how to report it, or she would not know how to deal it. And even otherwise, for her to be able to deal with her menstruation is a bit of a inconvenience or a bit of an issue, which the parents, given all other circumstances that they may have, they may be poor, they may be having not enough support, whatever. And then there are these tribal women, migrant women who travel all across the country. There are stories which I'm sure many of you might have read, that there were stories being reported about how these women working in these sugarcane crop cutting, the contractors out there were actually actively motivating them to take out their uterus, because every month, 5 days, they would lose their daily wage because they were menstruating and they couldn't work. So women had to actually make those choices about their health basis the economic aspect. Why I'm sharing these very, sort of may seem a little scattered, but there are these voices of women about their menstruation and menstrual health, which are not even included in the menstrual health aspect as yet. Forget about the larger landscape of health. So it's that kind of a journey that we have to take up. And the other aspect I'd like to mention is about how we've seen a lot of data being talked about today and yesterday also. But I think we need to make those connections which are, for example, for menstrual health, are missing right now. The connection between cervical cancer, the high rate of cervical cancer in this country, and the very bad status of menstrual health of women, or the economic poverty of women connected to their menstruation? I don't know. There is no data. So the research and the indicators that we're talking about, I think we need to have more fund, more resource being put into listening to women and really asking them those questions about their health, which they have somewhere taken it as a, this is part of my life, this is how it is. So making those connections with the data that we have, I think it's a very important task, and we need to go back to these very vulnerable pockets of women. And I think, if the larger infrastructure and the thinking about health does include these small needles which are bothering women, like menstruation that I mentioned, then we'll probably be able to bring in those things in the, like the simple thing about menstruation that I'm sure every woman out here has heard at some point, whether from her mother or from a doctor, that ye hota hai, aisa hota hai, पेट में दर्द हो रहा है, होता है. How is a woman supposed to figure out that, where is it that threshold of ye hota hai se aage baat badhegi, for her to actually think this is an urgent matter, I need to go to the doctor and show. It's not even included as something which is there. And believe me, when I talk about menstruation as a basic issue, it is something not just about women who are not like us. This is something about women like us in this room. How many of us actually go and ask a chemist that which pad is good for my skin, which pad does not have chemicals which will bother? It's the most intimate product. But we don't ask those questions. We don't know what goes into our pads. We don't know what is the thing which is good for my skin or not. We are educated women. We're not asking because it's not there in our mapping of our health that we are including menstruation. So I just stop here. Thank you so much.
Thank you, ma'am. Thank you so much for your insights and about the menstruation problems of menstruation and all. I just want to say, when we are talking about the sex workers or the marginalized population and the people and the women, those are living in jail or inmates of women, the most important thing that we are not going to understand the mental situation of these women. Because I have worked in the brothel areas and I have worked in the jail also. When I have met those people, तब वहां जाके निकल कर आता है कि वो किस मेंटल स्टेट से गुजर रही हैं. उनको एक छोटी छोटी, when if the woman is living in jail and she is not having proper breakfast, proper lunch and proper dinner, and she is pregnant, so what she can do at that time? और उनको वहां पे काम भी करवाया जाता है. इतना ज्यादा स्ट्रगल है कि अगर हम जाके उनसे पूछते हैं तो उनके इश्यूज बिल्कुल डिफरेंट हैं. और उनसे ये कहा जाता है कि या तो वो अपने घर से पैसा मंगा के हमें दें, जिससे कि वो उन सारी चीज़ों से उनको छुट्टी दी जा सके, उनका जो एक मशक्क़त करके एक चीज़ है उससे उनको रिलीफ दिया जा सके. अदरवाइज they are forced to do these things. तो these are the vulnerability जो एकदम और ज़्यादा बढ़ जाती है नॉर्मल पॉपुलेशन से. अगर हम हट के देखते हैं तो वहाँ पे ये vulnerability हमें और ज़्यादा जाती नजर आती है. And when I am talking about the sex workers, and when I was discussing with one sex worker, तो उनका कहना ये कि हमारे बारे में सोचता ही कौन है, हमारे बारे में सोचता ही कौन है. अगर हमारे यहाँ कोई प्रेग्नेंट हो गया तो उसको तो सोसाइटी एक्सेप्ट ही नहीं करने जा रही है. और हेल्थ कैंप्स की कोई फैसिलिटी नहीं होती. बहुत सारे मैंने एनजीओ के साथ काम किया था, नैको के साथ काम किया था, कुछ हेल्थ कैंप्स वो वहाँ पे लगवा देते थे. तो वहाँ उनको वो फ्री मेडिसिन एकदम, उनको लगता था कोई तो हमारे पास आया, कोई तो नॉर्मल पॉपुलेशन से हमारे पास आया जिसने हमारे बारे में भी सोचा. तो दे आर एक्चुअली दे आर going and they are thinking कि what is the, we cannot understand the vulnerability those are present over there in the brothel areas and in the jail. ये एक बहुत बड़ा इशू है जो कि हम एड्रेस ही नहीं करना चाहते और एड्रेस कर भी नहीं पाते हैं जब तक आप उनके साथ जाके जुड़ेंगे नहीं, और जुड़ना उनके साथ इतना आसान नहीं है, उनके साथ जाके जुड़े जाए।
एक चीज में जोड़ना चाहता हूँ।
यस प्लीज मैम।
I just wanted to say कि जो रास्ता आगे का जो when we were working on this issue and we are trying to see कि क्या किया जा सकता है, क्योंकि जो हेल्थ इंफ्रास्ट्रक्चर है वो बहुत बड़ा इशू है, उसमें बहुत सारे रिसोर्सेज जाएंगे. One of the things that we realized was कि खाली आप जाके बात कर लें और कहें कि आपको ऐसा करना चाहिए तो बहुत कुछ. आप किसी महिला से कहें कि आपको नहाना चाहिए, आपको साफ सफाई रखनी चाहिए, बट most times that woman can turn around and tell you कि भाई अच्छा नहाना तो चाहिए, आप बता रहे हैं मुझे, बट साबुन कहाँ है, पानी कहाँ है, एक एक्स्ट्रा कपड़ा कहाँ है, वो जो बेसिक जो मिसिंग है वो कहाँ है. तो we found the answer in mobilizing women. जो गूंज ने जो चुप्पी तोड़ो बैठक की बात की, जो हम हजारों की तादाद में महिलाओं के साथ करते हैं. The other aspect which we introduced is कि महिलाएं खुद मोबिलाइज हो अपने विषयों पे काम करके कुछ बदलने के लिए. Because we saw the health or the menstrual health as a kind of an opportunity for women to sort of say कि भाई हमारा मसला है. So they in villages across India, women identify their own issue कि हमारा कौन सा issue है, जैसे पानी नहीं है या private space नहीं है. तो we said अच्छा चलिए अब क्या करें, private space बनाते हैं और जो भी है उससे बनाते हैं. तो बहुत बार तो वो लिटरली पत्ते या वो लेके बनाते हैं, कोई छोटा सा एरिया लेके वहां पे एक प्राइवेट स्पेस उन्होंने बंद जगह बनाई. तो बहुत सारे लोग हमसे कहते हैं कि भाई ये क्या सोल्यूशन हुआ, ये तो बहुत ही बेसिक है, इसे तो कल मतलब 1 महीने में खत्म हो जाएगा. तो हम कहते हैं कि नहीं, बात उस फिजिकली कैसे बना है उसकी नहीं है. बात ये है कि एक महिला ने या एक ग्रुप ऑफ विमेन ने अपने लिए वो जगह क्लेम की कि भाई ये मेरी मेंस्ट्रुअल हेल्थ या मेरी हेल्थ एंड हाइजीन के लिए जरूरी है कि गांव में एक जगह हो. तो वो एक असर्ट करने वाली बात भी है कि आप अपनी हेल्थ को असर्ट कर रहे हैं एक लार्जर इकोसिस्टम में कि मुझे इस चीज की जरूरत है और मैं इसको तैयार करूंगी और हम महिलाएं मिलकर उसके ऊपर जुटेंगी. तो वो शायद एक रास्ता हो सकता है कि जो महिलाओं को अपने लिए खोजना पड़ेगा और उसके लिए खुद एक्शन लेना पड़ेगा, जो कि अवेयरनेस से थोड़ा सा आगे बढ़ के काम हो.
Thank you, Meenakshi ma'am. My next question to you, Professor Acharya. What is your opinion regarding women exercising their rights to health?
राइट्स टू हेल्थ ही नहीं, मेरे ख्याल से बाकी सारे राइट्स को एक्सरसाइज करना ज़रूरी है और महिलाओं के लिए तो कुछ ज़्यादा ही ज़रूरी है, क्योंकि इट्स हाई टाइम दैट वी स्टॉप डूइंग द लिप सर्विस. बहुत समय से ये बात वुमेन्स राइट, इक्वालिटी, जेंडर डिस्पैरिटी, जेंडर बजटिंग, ये तमाम सारी बातें हो रही हैं, लेकिन दिख कुछ नहीं रहा है. एंड दैट्स द पॉइंट आई वाज मेकिंग. आप कोई भी डेटा उठाकर देख लीजिए, जेंडर पैरिटी बाकायदा कायम है. अगर मैं 61 से लेकर 2011 के डेटा की बात करूं, आप एजुकेशन ले लीजिए, एम्प्लॉयमेंट ऑफ कोर्स हैज इट्स ओन इश्यूज ऑल्सो, लेकिन वो अपवर्ड ट्रेंड है, लेकिन जो गैप है वो बाकायदा कायम है. तो अगर हम पॉलिसी फॉर्मुलेशंस कर रहे हैं और कोशिश की जा रही है कि हम जेंडर बजटिंग करेंगे, पैरिटी लाएंगे वगैरह वगैरह, तो ये जो गैप है दिस शुड हैव स्टार्टेड टू टेपर एटलीस्ट बाय नाउ. जो अभी भी नहीं हो रहा है, इसका मतलब है कि देयर इज समथिंग व्हिच वी नीड टू सी विज़िबली the way we've been formulating policies, one, and the way we've been implementing policies. और वहाँ पे आके शायद as implementers of the policies we all behave in our own socio-cultural milieus when it comes to putting them together. For example, जब हम बहुत सीधी सी बात menstruation जैसे मुद्दे को, चूँकि हम उस पर चर्चा कर रहे थे फिलहाल, एक तरफ तो हम ये कह के चलते हैं कि भाई ये तो नेचुरल है, व्हाट, सो व्हाई मेडिकलाइज दिस काइंड ऑफ नेचुरल थिंग्स व्हिच हैपन टू वुमेन. लेकिन उस व्हाई मेडिकलाइजेशन में अगर मेरिट है, तो मेरिट ये भी है कि उसके बारे में हम इवनली बात करें, उसके बारे में हम उस तरह की सोच बनाएं जहाँ पे आपको ये कहने में कोई संकोच नहीं हो कि वेल आई एम मेंस्ट्रुएटिंग. या मुझे फलां किस्म का पैड चाहिए, कैन आई आस्क माय ब्रदर टू गेट मी वन। वो एक चीज़। दूसरा जो शायद मुझे लगता है बहुत ही अहम मुद्दा है, मेंस्ट्रुएशन से जो हमने सोशियो रिलीजियस कॉन्टेक्स्ट को जोड़ दिया है। जब आप कह रही थी कि महिलाओं को मेंस्ट्रुएटिंग वुमेन आर नॉट अलाउड, आई मीन दे लूज वर्क टाइम, वर्क आवर्स इफ द वुमेन आर मेंस्ट्रुएटिंग। It's not only that, they are prevented from working if they are menstruating because of the religious context कि जो भी फसल है वो इम्प्योर हो जाएगी या वो खराब हो जाएगी वगैरह वगैरह। वेरी सिमिलर टू, आप अचार नहीं छू सकते, आप दही नहीं छू सकते, आप पूजा के कमरे में नहीं जा सकते, आप खाना नहीं सर्व कर सकते वगैरह वगैरह। तो जब हम उस कॉन्टेक्स्ट को लाने की कोशिश कर रहे हैं तो मेरे ख्याल ये ज़रूरी हो जाता है कि वो कॉन्वर्सेशन हैज़ टू बिगिन फ्रॉम यू एंड आई एज इंडिविजुअल्स, देन ओनली परहैप्स जब हम RCH की और एम्बेडेड प्रॉब्लम्स, एम्बेडेड पॉलिसीज़ की बात करते हैं, प्रोग्राम्स की बात करते हैं, वो आएगा। दूसरा जो मीनाक्षी जी शायद मैं आपसे ही समझना चाह रही थी, जब हम ये कह रहे हैं कि वी एज इंडिविजुअल्स वी हैव टू क्लेम दैट स्पेस इन दैट विलेज कि ये हमारा स्पेस है, बाय डूइंग सो यस वी आर क्रिएटिंग दैट स्पेस फॉर वुमेन। लेकिन इस सारे करने में क्या हम स्टेट को एब्जॉर्व कर रहे हैं उसकी रिस्पॉन्सिबिलिटी से? वो रिस्पॉन्सिबिलिटी भी लाना उतना ही ज़रूरी है कि it allows or it makes, empowers, if I may use that word, women to be able to claim that space. शायद वहाँ पे हाउसिंग सोसाइटीज को देख लीजिए, हाउसिंग प्लान्स को देख लीजिए, वेयर इज दैट स्पेस फॉर वुमेन किचन को छोड़ के? थैंक यू।
Thank you so much, ma'am. My next question to you, Mr. Banik, this is from the audience side. Does gender inequality exist in the diagnosis of occupational duty?
So one thing that we have noticed, in the human development indicators, the reason why India get a lower rank has to do with the gender disparity that we see in the context of India. So two important things which is actually pulling down our HDI ranking in the world. One is the lack of gender equality, and the second has to do with the lack of trying to control the change in climate. So these are the two important things. And what was your question? That whether
does gender inequality exist in the diagnosis of occupational duty?
That data I don't have, but what I have is, if you look into the recent data, what is happening is the number of female participation in the workforce that has come down. Now, why it has come down, that is again a matter of debate, because as you were mentioning that in a particular village there can be a common space, but even within a village, if I control for the caste and creed, you will find that this kind of common place are not being used, And there are some suggestions and there are some studies which kind of say that even now, one of the reasons why you see at a village level women participation is falling has to do with the predominance of caste and creed within the village society. Okay. Of course, from the positive side, one can always argue that because the income level is increasing, you see the tendency of women to go out and seek for work, that has fallen. But at the village level, even that may not be true, because what is happening is, like last year, I was talking to few of the women entrepreneurs. They wanted to open what they call salon, beauty shops in village, But they had big problem in terms of access to finance. They had big problem whether a particular caste in that village can actually become a woman entrepreneur. So that caste and creed is still playing a dominant role when it comes to the woman empowerment or trying to do something on their own.
Just wanted to add what Nilanjan has just said. I want to bring in one particular occupation here, the scavenging occupation. Now, this is one occupation, I think, which connects not only with health, but also the environment. And both men and women are involved. We know the surface cleaning, it's 90% of it, which is done by women. And women of both communities, both large communities that we're discussing at the moment, Hindus and Muslims. We have a very good study on the Muslims in Hyderabad who engage in scavenging activities. And when it comes to disaggregating, and I can come from the field little that I've understood, a good number of women, something to the tune of ranging between 80 to 90% have reported respiratory ailments because they are the ones who are cleaning, the brooming, the surface cleaning is there, a lot of dust raises itself and infects them. Similarly, when you're looking at men, most of whom, again, 90% of them are engaging in drain cleaning and sewer cleaning, and they have reported ailments which range from skin to kidneys to ear and eye ailments to the extent of losing sight and hearing. There's a very good study by CEC, which was done way back, I think, during late 80s and 90s, repeated subsequently, tells us very, very clearly that this is what is happening. And there's a good number of literature which is suggesting it. So the point, therefore, I'm making is when it comes to occupational hazards in terms of work, there is a very neat divide in terms of occupations and how they're affected. Stress and anxiety in men and women who are engaging in high-profile jobs are also very evidently different when it comes to men and women. And I think that was the point which was marked by Dr. Ambedkar's work in mica mine workers to restrict women's entry into the dikes as compared to men because of the hazard which was engaged in. Thanks.
Thank you, ma'am. Next question from the audience. Other than menstruation, what are the other health concerns for vulnerable women? This is question for you, ma'am. That's one audience.
Well, I think since it is an important issue when it comes to women's health, if you really go by the public policy formulations and formulation of policies for women's health, a lot of concentration has been on reproductive health. And very, very, very clearly we know why it has been on reproductive health and not women's health. You're addressing, you're talking of a country which has been reinstated the growing population, and therefore you have to address it vis-a-vis the reproductive health, which is where you can kind of attempt some kind of containment. Besides menstrual health, the emphasis came on to rest on menstrual health for the simple reason that a lot of it gets connected with other kind of health conditions that women may be experiencing. And remember, we've not really got into the realms of the mental health conditions which women and men differently could be suffering from. Let's talk of COVID in this context. The very idea of closure of healthcare services for a given duration, if I can quote from Delhi, 24th of March to 5th of June 2020, the hospitals wherein the maternal and child care was being provided were diverted, their services were diverted towards COVID. And given our fertility rate, what was happening to women who needed this care, ANC and child delivery and PNC also, with postnatal care and antenatal care. So a lot of social positioning that we do for women in terms of their role in the society has a lot to do with childbearing. And I think that's why we keep harping about women's health, vis-a-vis reproductive health. And the argument, therefore, I am not too sure when you said health, did you mean beyond, looking at beyond reproductive health too? My emphasis would be yes, looking at beyond reproductive health too, because what is being experienced during the reproductive period will certainly rest on what was experienced prior to that. What is it that I ate as a child? What did my mother eat when she was pregnant with me is what is going to govern and determine my reproductive health. So the problems could be not only in terms of physical health, but also in terms of the stress that I could be experiencing. For example, because of a certain sociological conditions which are existing in my family, and I'm not able to perhaps go and meet out my friend. So a lot of, or I'm not able to study further. I'm not able to continue school because the school doesn't have a toilet and I have to discontinue, I have to drop out. And these are perhaps the stresses and anxieties which we don't recognize when we are talking about women's health. So I don't know if I'm addressing the question in the right direction, but something of this sort becomes very, very elementary in terms of recognizing the larger context of women's health beyond what is visible. Stresses which have been created during COVID, the fact that you cannot stay home, was something which was considered as the best policy to contain COVID. Now, stay home in the context of, let's say, a situation where domestic violence persists. And I'm sure we've had ample literature suggesting that this is where contentions have been staying with somebody, that somebody will have ample amount of time being with you alone to do whatever that somebody wants to do with you vis-a-vis the perpetration of violence for that matter. So, and that will generate some kind of, mental health issues. It may not necessarily reach the context of a psychotic or neurotic degree, but then prior to that, we have a lot of stress, we have a lot of anxiety to deal with. We don't really get into, we don't really bring into the fold. Again, a lot of stigmatization is there. The moment I wish to see a counselor, okay, so there's something wrong with you. We are not open about our own health. We don't want to accept certain things precisely because there's a lot of stigmatization which is, related to it. And therefore, that's where the containment needs to be there. Shazia, thanks, I'll stop here.
Thank you so much, ma'am. Mr. Banik, this is for you. What are the major mental health issues of women?
Mental health issues, I haven't actually thought about it because in terms of so basically, let me again go back to the data. What we have found is there is a clear direction, and this is a unidirectional causal effect that we see, that in terms of women who are getting married early are the ones who don't have that much amount of education. The women who are actually not graduating, they are also the one who tend to suffer from all this woman-related health issues, again, coming from the NFHS data. The third thing is we also found that in terms of participation in the local labor market, I mentioned about the caste thing, but in addition to the caste, we also found it is the level of education which also matters. So that would be my brief answer because I haven't thought about this question which just came to me. Thank you.
So thank you so much. Because of the paucity of time, I'm going to end the session here. Yes.
Yes.
One of the physicians has said that this lack of intake of vitamin D again increases the number of diseases. So have you tried to study that?
No, ma'am, we haven't actually looked into that aspect, but clearly what we have seen that if I control for the religion, the Muslim household, they tend to actually use toilet more often compared to the Hindu or Christian and other community household. For instance, even if you go to the state of Tamil Nadu, you will find that it is by norm that the lower caste Hindus, they are the ones who actually clean the excreta of the higher caste Hindu. So that has not led to elimination of open defecation if I look into some southern Hindu dominated states, because that is culturally given. By the same notion, if you control for this religion, you will find in Bangladesh, which is predominantly a Muslim dominated society, the level of death arising because of this open defecation is much, much lower than what we tend to get into find in India. But that's a very interesting question which we haven't seen about the vitamin D aspect of it. Yeah, thank you.
अच्छा, नहीं तो मैं इसी पे 2-3 और चीज़ें ऐसी हैं जो जिस पे शायद हम अगर थोड़ा सा हेल्थ का रिसर्च की शायद ज़रूरत है. फॉर एग्जांपल वुमेन, जैसे आप असम में देखते हैं, वुमेन हु कैरी दीज बिग लोड्स ऑन देयर बैक, उसका उनके हेल्थ से क्या जुड़ाव है. या वुमेन हु सो द पैडी, उनका अपनी हेल्थ से इतनी देर वो पानी में खड़ी रहती हैं या इतना झुक के वो पूरा टाइम, या सिंपल मीनोपॉज, उसका क्या कनेक्शन है. या जो महिलाओं को जब चाइल्ड रेयरिंग का जो सबसे बड़ा काम महिलाओं के हिस्से आता है, तो वो लगातार एक बच्चे को उठा के, स्पेशली माइग्रेंट वुमेन जो सारा टाइम उनको उठा के काम करती हैं, उसका कनेक्शन उनकी हेल्थ. तो ऐसे बहुत सारे जो औरतों के फिजिकल लेबर या फिजिकल होने से, जैसे आपने बुर्के का जिक्र किया, वो उनका बहुत, इट्स लाइक सो इंट्रिंसिकली कनेक्टेड टू देयर बॉडीज कि आप अगर उसको नहीं टच कर रहे तो आप उनकी हेल्थ का एक बहुत बड़ा हिस्सा और पैटर्न एक मिस हो जाएगा.
साड़ी यहाँ पे वेस्ट के पास साड़ी बांधने की वजह से स्किन रिलेटेड जो कांगड़ी का जो कॉन्टेक्स्ट है रेस्पिरेटरी इशू, so there are studies which have come up, but I'm not familiar with. जी.
कॉन्टेक्स्ट में वुमेन्स मूवमेंट जो बड़े-बड़े जो फेमिनिस्टिक मूवमेंट हुए हैं, उसी का सब कॉन्टेक्स्ट सबटेक्स्ट जैसे उसमें आया है, तो वो भी अपने आप में एक बहुत बड़ा बात है कि, एंड ऑल्सो आई थिंक फॉर अ सोसाइटल क्वेश्चन मार्क कि हाउ मच डू वी केयर.
Thank you so much. We have gone through the journey from fieldwork to women's health in social fabric to NGO role. I've end this session over here. Thank you very much for the wonderful discussion. Thank you.